So the idea that there's no flexibility just doesn't ring true, and I think you have to read the bill for what it is. We put plenty of triggers in here. Our intent is very clear.
Since most of you have this in front of you, he's going to go ahead and tackle question 4. Respond to what you want to in question 3. And question 4 is just where are we right now in a commitment from the federal government? That question.
Okay. All right. So, a couple things I want to respond to in the points that that my colleagues here on the right, on my right, made just a minute ago. So first, on the issue of access to care and the argument that Andy made that if we don't expand Medicaid, there's no other option to care for these patients. There's no law that says health insurance has to cost $6,000 a year or $9,000 a year. The reason why it does is because the Medicaid program requires it to, effectively, because of the type of coverage that Medicaid forces states to offer. You can actually cover people for a lot less by giving them catastrophic coverage, health savings accounts, and other ways to access primary care. And this is something the Medicaid program does not do well. So in the state of Arkansas today, Medicaid pays a fraction of what private insurers pay to cover the care of a Medicaid patient. Now, the private option bill actually addresses that to a large degree, so that's not a big problem in this bill. But in general, just because you give someone a card that says they have health insurance doesn't mean that they have access to the care they need. Just because you're spending a lot of money on someone, giving them an insurance product, doesn't mean they have access to the care they need. A lot of it has to do with the technical aspects of how you design the insurance plan and how much you pay for care. So just because you give, not all coverage is created equal. I want to make that point because it's very important. A lot matters in terms of how you design insurance. And again, I think that's a point that these guys have been very conscious of. But you're still dealing with the Medicaid program and all the inflexibilities that Washington imposes on the Medicaid program. Now, another point I want to make is about this issue of what the federal government will do if they decide to cut the spending, cut the rates, and this trigger. Now, there is a trigger in the law, that's true, and that would hopefully have the effect that the authors of the bill hope it will. That is to say, if the federal government changed the matching rate for the Medicaid program and spent less money in Arkansas, then Arkansas could just wipe out the program tomorrow. That's one possibility. There are other things that the federal government can do to save money, though, and perhaps the bill could be amended to address this, but these are still significant issues. So, in the estimates, the cost estimates from DHS in Little Rock, they estimate that over the next 10 years, $436 million will accrue to the state government from a tax on health insurance premiums that will generate a lot of revenue because of these private insurance plans that will be used for this private option. Another $715 million, DHS says, will come from the economic impact of all this money. So it's kind of like, remember the stimulus bill in 2009 where Washington said we're going to spend $1 trillion and we're going to make the economy really grow? And what happened? Nothing happened. And yet DHS's estimates assume that $715 million of tax revenue will accrue to Arkansas because of all this money that's slushing through the healthcare system. I'm a little skeptical that $715 million of tax revenue is going to accrue to Little Rock because of all this money sloshing through the system. And if Congress cracks down in Washington, if Congress cracks down on these premium taxes and says, you know what, state governments, you can't have these taxes because what you're basically doing is forcing us to spend more money on Medicaid because you're taxing the insurance plans. It's this kind of like money laundering situation. If they crack down on that, that's a whole other set of money that Arkansas loses. So a lot of the assumptions in terms of all the tax revenue that's going to accrue to Arkansas from the private option are unreliable, or at least are based on promises that Washington may not keep. Now let me go to question 4 here, on where are we at at this moment. Now, I'm not as qualified to answer this because, of course, I'm not talking to Kathleen Sebelius, Andy Allison is, and Senator Sanders is talking. I'm not talking to Kathleen Sebelius. They're better to answer the question of where things stand today. But I can tell you the few things I said before. And we've talked a lot about numbers here tonight, and I'm sorry about that. But really what this comes down to at the end of the day is, do you trust Washington? If you trust Washington and you believe that what Kathleen Sebelius says today is what she's going to say 3 years from now, or what a future administration is going to say 6 years from now, then you should support this bill. But if you're at all worried that they might pull the plug on this at the end of 2016, then you might want to be concerned. And here's why. So on Good Friday, right before Easter, Kathleen Sebelius put out a memo where she said, under the Medicaid statute, and this is technically accurate, under the Medicaid statute, we can issue waivers and give states a little bit of room to experiment with their Medicaid programs. The biggest requirement that the states have to meet is that whatever they do experimentally, the cost of that program has to be comparable to what it would have been under the traditional single-payer government-run system. If it is not, if it turns out to be significantly more expensive, then HHS can pull the plug and say, you know what, we tried it your way, but it's costing us a lot more money, so we're not going to do it anymore. Now, DHS in Little Rock has estimated that actually the private option will cost less money than a traditional Medicaid expansion using the traditional government-run single-payer type approach. I don't know of many other people outside of DHS and Little Rock who agree with those estimates. Pretty much everybody, left or right, thinks that the private option will actually cost a lot more money than traditional government-run Medicaid, because it's using private plans, it's paying doctors and hospitals more. It has this premium tax, which drives up the cost of insurance. Now, some of these things are good things. It's a good thing to pay doctors more because it gives people better access to care. But HHS is going to look at that in Washington and say, you know what, your plan is costing us a lot more money. We told you that if it cost more money, we'd pull the plug. And it's required, HHS has declared, that all state waivers for Medicaid, the Medicaid expansion will expire on December 31st, 2016. So on January 1, 2017, Arkansas might wake up with a very different Medicaid program than the one they thought they were voting for.
And if we